Chapter 34, Caring for the Special Needs Child. This chapter, we're going to talk a little bit about the impact that having a special needs child has on the family. We're going to be talking about some support that the families need. We're going to talk about ways that families can help the child get to that optimal level of functioning. We're going to discuss early intervention and public school education for that special needs child. We're going to talk about transitioning the special needs child from the inpatient facility to the home and from the pediatric to adult medical care. We're going to talk a little bit about end-of-life care, and then we're going to talk a little bit about some death and interventions. So a special needs child, according to the Maternal Health Child Health Bureau, is children with special needs are those who have or at risk for chronic physical, behavioral, or emotional condition and required health and related services beyond what a general child should do or need. Children who have terminal illness are otherwise dying or require additional care. So nurses wanting to work with special needs child can work in the outpatient setting, inpatient setting, and nurses sometimes in that outpatient setting are filling roles such as a case manager and a nurse when you're dealing with a child who's dying or has a lot of medical needs. Numbers are increasing of children with chronic illnesses, and those kids are being streamlined into schools now, depending on what their illness is or what their disease process is. Lots of high-tech equipment, treatments, so it's their care is becoming multifaceted. So what do the children need at this point? So prescriptions, medical care, they'll need occupational therapy, speech therapy, emotional therapy. Financial support is really important because this can be very costly to parents. They can have a good portion of the parents with children of medical needs are often uninsured or insured inadequately. It's very challenging time for them. Parents are devastated initially, and then what their goal is to protect their child. And then preserving that family function, that family-centered care is important. Things we need to do is to empower them through this process. Having a sense of, having special needs for the child, what does that mean? When we think about Erikson stages, which I mentioned here on the slide, or I showed a picture of, that infant, their coping is affected. The infants fail to develop that sense of trust that we talk about with that attachment. Other caregivers are involved, multiple agencies, and then they may not be able to go through that sensory-motor explanation. They might not get that stimulation depending on the level of disease they have. As far as a toddler, remember the sense of autonomy versus shame and doubt, so they might not develop that autonomy because they're always relying on someone else for their care. Their motor and language development could be delayed. They just may not be able to ever become autonomous. The preschooler, we talk about that sense of initiative. They may have limited opportunities. Socialization is a really big deal for kids with chronic illnesses. They may not be able to be out with other people, depending on the situation. They may be more withdrawn. Their body image may be altered, and so that would be really detrimental to their self-being. Remember, those preschoolers are magical thinkers, so they may have feelings of guilt because of their condition. The school-age child may have limited opportunities to learn those industrial skills that they'll need later in life because of limitations with their physical condition. Though socialization is limited because they may not be able to go to school, so they don't have those type of relationships. Adolescents, again, it's that self-concept. They feel they're different from their peers, and this can really hinder their identity. So a lot of times the adolescents without diseases are developing sense of being away from their parents, but kids who have these special needs are more dependent on the parental unit, the family. And so they may feel that they're not accepted by their friends because they're very different. Sometimes parents with children with special needs become overprotective, and so that can mean, limiting their independence. And so sometimes that is a problem, or the parents may be overly more giving them anything they want, overly indulgent, and that can cause problems later. So what impact does it have on the family? Well, everybody experiences things differently, but raising a child with special needs is really not what parents plan to do. They may have some indication that there's going to be some problems in utero, but not always. Sometimes it's after the child is born. There could be some problems with the anger, so going through the stages of death and dying. And but they always will have hope, their hope that the child will, be able to do things for themselves, that there may be some research going on in that disease. So they always try to have a hope for their child. Overwhelmed. So overwhelmed with all the care, the 24-hour care, continual care. Like I said, they can experience sadness. I like this little picture I found on the internet. It says, "I'm not a superhero because I am a parent with special needs. That I'm a supporter of the superhero." They worry about the care. Parents worry about that. They worry about financial issues. They may feel very guilty. Maybe they feel overwhelmed. Maybe they feel guilty because they wish that this child was maybe not alive because it's a lot of work. There's a lot of emotions that go on in situations like this. I remember a case where a child was born with multiple congenital disorders, and he lived, and he had a feeding tube, a trach. He was on special formula because he had some stomach problems. He was constantly in the hospital with infections. And after he passed away, I think he lived for a couple of years, and after he passed away, the mother actually came back to thank the nurses because she had always come to the same hospital and got great care. And she said that it was almost like a weight was lifted off of her. And she didn't really know what to do with herself at this point because she was a caregiver and that child was gone, so her job was done. And she was sort of at loose ends for a while. She got some counseling because she needed to fill that void. She wasn't used to sleeping all night without disturbances. She wasn't used to not going to the doctor. She felt that her other children maybe didn't have the kind of childhood that other kids have because everything revolved around the sick child. And so she felt like she needed to spend time with them, although they were grown. Maybe she should go back to school. Maybe she should go back to work. She was just kind of lost. But she did say that, it was this relief because she knew he was never going to make it through the childhood years. And it just, although she loved him, she took great care of him, but it was a sense of relief that he was no longer suffering and things like that. So, but sometimes they do have that guilt, or sometimes they have that feeling of, what's my purpose now in life? Because my whole purpose was caring for this child. So some of the stressors of living daily with a child with a special needs is that sometimes they have to change their housing, so that sense of security of having that home, sometimes that's a change. Sometimes they have to move to a bigger home. Sometimes they have to move to an apartment. I've even known of people who have had to move to a different state because, there were services in a different state. If they lived rurally, maybe they couldn't get the services and care. So sometimes there's some that disruption. Technology, so making sure that they have the technology with all the equipment, sometimes home ventilators, suctioning, things like that. And then supervision of all of that, even if they do have some help in the home. They have the care of the child, medications, treatments, incorporated into their daily life. One of the parents may have to quit their job and stay home. Holidays and vacations can be affected because it's sometimes painful or difficult to plan these vacations. And then social life. So think about a social life for the parents. They may not have any type of a social life. According to your book, mothers carry more of the burden. The father sometimes will be the working person and the mother will take care of all the, do all the care. They can feel isolated. It's really important to hook them up with support groups. And then sometimes these parents don't take care of themselves. They don't go to the dentist. They don't go to the doctor for checkups because all their life revolves around this sick child. So they often neglect things for themselves. They can have an increased sense of developing depression. It's a burden, the caregiver burden, that role conflict. So, you expect that your child becomes more and more independent as they grow up and do things for themselves, but kids with special needs can't always do that. Financial burden too. And then, maybe we can do some referrals for respite care, things like that. And then there's also some stress involved in change in prognosis. So sometimes as kids may be progressing into developing more problems, increased symptoms, maybe spending more time in the hospital, it can be stressful. Sometimes the parent's absence because they have to work. And then some of the stress involving the developmental changes. Also, when we think about all the stresses, you really have to think about, like I said, other siblings, how that affects them, how, like you said, affecting the financial aspect of it. Also, sometimes if parents, when a special needs child comes into the family, it can either strengthen the family, sometimes it can break families apart because of the stress involved in it. I have a little picture about school nurses. So school nurses are a great help with these kids with multiple problems. So if they integrate them into the schools, the problem is that school nurses are spread between 3 and 4 schools now. A whole district will have just one school nurse, and then they'll have medical aides at the other schools. And so kids who have complicated medical needs, it's harder for the nurse to spread themselves to see all the special needs kids. So vulnerable child syndrome is, it's a clinical state, and then it has to do with the parent's reaction to this event. And knowing that the child's past is going to have a long-term effect on them. The parents often view their child as high risk. They often are wanting like more and more testing done, more and more research done, trying different things, maybe some non-pharmacological things or some FDA non-approved medications. They sometimes visit the healthcare providers very frequently. Children at risk for this are your preterm birth babies. I talk a lot about preterm low birth babies, kids with congenital anomalies, jaundice, handicaps, or accidents that the child's not expected to recover from. You all hope that, when you have a child, that they're going to grow up to be a productive member of society, and it's not the case with these kids. Parent has a difficulty separating themselves from the child. Often they are over involved with the care, which I'm not saying that as a bad thing, but they are the caregiver. They're very picky about how people take care of them when they come into the hospital or doctor's appointments or things like that. They try to retrain that control. Sometimes they don't want to discipline the child because they don't want to upset them. I talked to a mother one time who said that she knew her son was not going to live past 10 years old, so she didn't want to discipline him at all. She wanted just him to be able to do what he wanted to do in life. So focusing on the family, we talk a little bit about siblings. It affects them, like I mentioned earlier. They sometimes wish they had a typical brother or typical sister, and they sometimes get pushed out of the way, their needs. Sometimes they will regress due to the lack of attention because the special needs child is requiring more time from the family. Case management advocacy, we try to provide that. Screening, ongoing assessments, provisions of home care, so getting them the resources that they need to keep the child at home. Technology, making sure that they have those resources. I noticed that some of the kids who have special needs are limited with supplies that they can get. So for instance, we had a mom who came to the ER because she had run out of catheters. She had to straight cath her kids several times a day. I don't even remember what the medical condition was, but towards the end of the month, she would run out of them because she was only allotted so many through her insurance company. And she could not afford to buy them. So she'd bring them into the hospital because she had run out of the catheters. Now, we would catheterize the child for her, and then the doctor would say, just give them a few catheters to get through the end of the month. I feel bad for them. Probably something we shouldn't have been doing, but we did. I felt like it saved the hospital another visit because she would just have to come every day, several times a day, to get what she needed. So unfortunately, there are supply issues, especially if you're on access, things like that. And so we do try to get them all the resources that they can. Your social worker, your RN case manager are really good to have involved in these cases so they can, help with that. The biggest thing is to try to get them out of the hospital, get them home. Again, it's a little harder. It takes a lot of time to set all this up if it's a new onset diagnosis from birth or something changes. So early discharge planning, because you have to get a lot of pieces in place for them to go home with probably referrals, equipment, nursing, occupational therapy, physical therapy. Coordinating all those things is important. Making sure the parents know how to take care of them. So if they have a tube feeding, make sure they know how to do that. Giving injections, giving medications. So basically, you're doing a lot of education, and before that child is discharged, the family will have to show that they can care for the child and actually perform all the duties that they need to do. Lots of follow-up care. So there's a building over behind TMC. It's called the Square Compass Building. That building is for special needs kids, and they have sort of like one-stop shopping for them. They have a occupational therapy department, physical therapy, nutrition, pharmacology, speech therapy. So it's all in one area, and so they deal with a lot of the special needs kids and all of their resources that they need. Growth and development, we're going to talk about that. What kind of care is going to go on with that? Long-term risk for the premature infant. So the premature infant is more at risk for having some developmental delays, special needs, things like that. Sometimes they have a chronic lung disease called bronchopulmonary dysplasia. They sometimes have some cardiac anomalies, growth retardation, poor feeding. We went over that a little bit with our G-tube in skills. Anemia. They sometimes have a very bad reflux, so gastroesophageal reflux. They're at risk for sudden infant death. Rickets because of prematuria, so osteopenia. Hydrocephalus, we talked a little bit of that in skills. They can have to have a shunt put in their head. They have hernias. They can have vision problems, hearing problems. So a lot of different things that can go wrong as far as delays, especially in the gross and fine motor, language, and sensory. So really those premature infants, the more premature they are, the more they are at risk of developing also some behavioral conditions like ADD, learning difficulties, and then they are at risk also for cerebral palsy. We talk a little bit about failure to thrive in this chapter. So as far as failure to thrive, it's a term used to describe inadequate growth in infants and children. So remember we talked about the growth chart and where they're plotted out on the growth chart. If they don't demonstrate a appropriate weight gain or length or head circumference, if those are not progressing, then they may be labeled as failure to thrive. So, but it's more common in the kids with special needs. So nutrition is really important for that brain growth. And sometimes they have problems eating, have problems tolerating food. They have sometimes malabsorption, so they're not absorbing the nutrients, continuous diarrhea, vomiting, alterations in metabolic disorders, and then they can have physical and cognitive disabilities. Also causes of failure to thrive would be neglect and abuse, lack of the maternal interactions, poor feeding techniques. Sometimes it's lack of parental knowledge. Sometimes it's the parents are sick, they have illnesses themselves, or sometimes drugs and alcohol. Poverty is a single contributing risk factor. So the key is to identify the failure to thrive early, and then get these resources in place. And then, is it a nutrition problem? Is it, their gross motor skills, fine motor skills? So you really want to identify those and take early action so that they can hopefully get to the highest level of functioning. Resources, again, we need to make sure that kids have educational opportunities when they're in the hospital. We have to make sure that we're giving those resources. There are teachers about the hospitals, so they can, if kids are able to, they can catch them up with, learning. Financial resources, so if they're not on access, getting them hooked up with those resources. Respite care is when they can, they'll have people coming to the house and letting them get away for periods of time, and trained people. And then any kind of complementary therapy. So sometimes people will try things. There was a little girl that was brain dead from a hypoxic injury, and the parents wanted to try hyperbaric chamber therapy. They had read something about that. And so although there was not a lot of evidence to support that, they were able to facilitate that and got her into some sessions of hyperbaric therapy. In the end, it didn't really help, but sometimes they're grasping at straws for anything, and I would too. So transition from inpatient to home, like I said, it takes a lot of planning. You've got to have a lot of pieces in place. There's a lot of moving parts that need to be in place before they're sent home. You don't want them to get home and not have the correct medications, treatments, dressing changes, catheters, things like that. You want to make sure that that's all taken care of. And then that respite care is of ultimate importance, because they need to be able to, get away Sometimes the respite care is at night, so the parents are able to sleep all night. So there's a lot of home health nurses that do that type of care. I talked a little bit about homeopathic and herbal medicines, pet therapy, getting the pets in the hospital. Hippotherapy is horse therapy, and they've been trying it a lot with autistic kids. Music, massage, they will try to incorporate any type of that type of therapies with the kids. And then one of the biggest things is moving from that child with a chronic illness to now you're an adult with a chronic illness. You all know that a pediatrician's focus is a little bit different than an adult doctor's focus. When you go to an adult doctor, you're expected to, function as an adult. So that transition is hard. Maybe the parents always control the medications, and now we're kind of giving that up to the child. And are they going to take it? They've turned 18. Are they going to be taking them as they should? So there's a lot of planning that goes into place. Sometimes there's little lapses. I know a friend of mine, she has a child who had a liver transplant, and he's on a lot of medications, things like that, and he turned 18, and so they were trying to transition him to what he takes, when he takes it, and he just stopped taking his meds altogether. He was going out with his friends, things like that. He ended up back in the hospital. So very troubling, because his mom, who's a nurse, had really made all these plans, and she had taken such good care of him, and now he's just kind of living on the edge and doesn't understand how sick he is. So causes a lot of family disruption too, because even though you worry about your kids no matter what age, these kids are more vulnerable. I don't know why it's changing the size, sorry. So the treatment rationale, why they're getting the treatments, signs and symptoms to look for, danger signs when they're sick, when to call the doctor, how to apply for insurance, all that kind of stuff. Finding a doctor who can understand a special needs child as an adult is sometimes hard to do that change. So healthcare personnel, I'm sorry that this is changing these slides. I'm not sure why, but end of life decision, we talked a little bit about end of life last week, is making sure that the families and the patients, if they're old enough, are able to ask questions, are able to understand the process, and having that order to withdraw care if that's going to go on, but making sure that everybody is aware of all of the choices and the decisions. So do not resuscitate orders. We talked a little bit about this last week. Is do not resuscitate, and then allowing natural death. It's one of the hardest decisions to make for a family, and allowing natural death is withholding cardiac CPR, and then it almost feels for a parent like they're giving up. They're just wishing their child to die. If the parents choose palliative care rather than continuing some curative care, the focus on the care is changing, and making sure the family is involved. They also can pick and choose what extent of resuscitation. They also can change that their mind when they want to, and that's always a consideration that we need to be aware of. So guidelines for organ donation. I don't know what the heck happened to this this slide, but let me see if I can change it. There you go. So organ donation, we have living, after natural death, and after brain death. So we talked a little bit about this too. So the discussion should be separate for each type. So the expenses are not on the person donating, it's the person receiving it. You can't buy organs. in this country. There's a process, and people get placed on the list. One of the biggest things is parents want to make sure if they donate organs, is there, are they going to look bad if there's a funeral? So they need to be assured that, they won't be able to tell. And then sometimes family, cultural, and spiritual beliefs, you want to consider those. So certain practices they do for a death and things like that. And then palliative care. So palliative care and hospice care are a little bit different. Your palliative care is managing the symptoms, and then hospice care is that comfort care at the end of life. So respecting the family's wishes, the child's wishes, if appropriate, and then getting them the resources, support, really explaining the difference between the two, and then, like I said, allowing them to change their mind if they want to. Palliative care is really managing pain and discomfort, but also providing nutrition, whereas hospice care, they will stop the nutrition portion of that. And then the support that goes along with it. Okay.